Good morning, or good afternoon, as the time may be. My name is Josh Davis. I'm a third-year emergency medicine resident at Penn State Hershey Medical Center. I'm going to talk to you briefly about my research on laboratory values and symptom duration in pediatric appendicitis. I did this work with Dr. Kasmire. She is the medical director of our pediatric emergency department, as well as our resident pediatric ultrasound guru. So a little in the ways of introduction and background. So I think we all recognize that appendicitis is a common surgical emergency in children, often cited as the most common surgical emergency in children. Also is often cited as the most common source of lawsuits and litigation as a misdiagnosis or delayed diagnosis in children as well. I think we're all well versed in the complications of appendicitis, which can lead to abscess, perforation, sepsis, and the most feared complication of unhappy parents, as you can see here. Given that abdominal pain is a very common presenting complaint and that all children can't be imaged all the time, various people have worked for the past many years to develop scores and systems and ways to risk stratify who needs further imaging, including the pediatric appendicitis score, the Alvarado score, and many of these include laboratory evaluation with a white blood cell count or an absolute neutrophil count. So we decided to investigate some of the test characteristics of this and compare that against a newer test that's become available in the last couple of years, which is C-Reactive protein, and has been evaluated in appendicitis and has shown kind of mixed results in its value in appendicitis. So in the ways of methodology, we did a retrospective review of all children presenting to our emergency department from June 2017 to June 2019, being evaluated for appendicitis. The way we identified these patients was by the imaging order to evaluate for appendicitis. So patients who had either an ultrasound or an MRI ordered for appendicitis. Yes, I did say MRI. We routinely use MRI in children to evaluate for appendicitis. We don't use CAT scanning unless there is another reason or another differential that we're looking for. We previously published on our rapid MRI protocol, and when that got finalized, the rapid MRI for appendicitis as well as the order for it was around June 2017, and when it was thought that we could get reliable data, which is why we chose that date. As far as the diagnosis of appendicitis, we used pathology for the positive appendicitis and clinical follow-up for negative appendicitis. We're really the only pediatric center near our area and the only place that would do really pediatric appendicitis surgery other than the oldest of children who would be qualified possibly as young adults and would be done at other centers. So we thought that follow-up would be pretty reliable at our institution. We abstracted demographic data, laboratory values, imaging results, symptom duration from all the patients of these charts manually. So a little look at the results here. You'll see that we had 539 children with a mean age of 11 years old and about a 60-40 split of male and female. In the middle column here, you'll see the test characteristics of various common tests based on their prior cutoffs that have been described in the literature. So you'll see both white blood cell count and ANC have a sensitivity between 85 and 90%, and a specificity between 65 and 70%. And then CRP at the bottom, you'll see actually grossly underperforms both of these tests. So a sensitivity of 73% and a specificity of 58%. So really doesn't add any value if you look at this data as it is. Using our specific data, we found cutoffs of 11,360 for white blood cells, an absolute neutrophil count of 7,800, and a CRP of 0.44 milligrams per deciliter. And you'll see that using those, we slightly improved the test characteristics overall, but really no major difference between those values. And you might wonder where those values, those very specific values came from, and they of course came from our receiver operating characteristic curve, which you'll see here. And that red line is the C-reactive protein, which really, again, is evidenced here to underperform both white blood cell count and absolute neutrophil count for basically all realms of the spectrum here. It is important to note that there were 3 patients who had appendicitis and did not have any laboratory abnormalities. They had symptoms of less than 1 day, and then almost a week in the one patient. But given that, we decided to look a little bit deeper into our data and see if we could use symptom duration to help further stratify which of these labs might be helpful. And you'll see in the top two rows here that the test characteristics of white blood cell count and absolute neutrophil count really don't change that much. Based on symptoms, you maybe gain a little bit of specificity by using white blood cell count and absolute neutrophil count at symptoms greater than 1 day, but the sensitivity really doesn't change at all. However, if you look at C-reactive protein down here where that arrow is, you'll see that at symptoms greater than 1 day, the sensitivity of C-reactive protein jumps up even higher than that of white blood cell count and absolute neutrophil count, so almost 90%, with very little loss of specificity. And we found this to be a pretty interesting finding. If you don't remember the results earlier of what CRP's overall diagnostic characteristics were, you'll see here a sensitivity of 73%. So very interesting that you can add a lot of sensitivity by using CRP in patients with the symptoms greater than 1 day. So a little discussion around this. So the first thing to note is the cutoffs in our data set were very similar to those found in prior literature, which adds some base validity to our data that we are kind of working off the same data that other researchers have looked at. Really interestingly, and probably the most interesting thing we found in our research was the high sensitivity of CRP for patients with symptoms greater than 1 day, and really little loss of specificity when you did that. Not that CRP is super specific to begin with, but you can really add a lot of sensitivity for using that in patients with symptoms greater than 1 day. And probably CRP overall doesn't add a lot of value to be used routinely in all patients, but if you're looking in this subset of patients with a CRP for symptoms greater than 1 day, and you're equivocal about whether you're going to obtain further imaging, this may help sway your diagnosis. It is important, though, also to note that no lab test is perfect. Obviously, we had 3 patients with appendicitis who did not have any lab abnormalities, and that none of these tests is 100% specific, so you obviously have to take your pretest probability into account in whether labs are going to add value to the evaluation of your patient or not. I think in some of the limitations that we'll talk about, so of course this was a retrospective study, so it comes with all of the limitations and flaws that are inherent in retrospective data. So not all patients had all laboratory tests done. Also, not all patients had pathology done. I think, the ideal researcher would want pathology on all of these patients. I think anyone who's practical realizes that that would not happen anymore in any instance. I think one of the other limitations that's important to note is we use imaging orders to identify the patients in our subset. And there are probably some low-risk patients who didn't have imaging done and are probably not included in our sample size here. Probably didn't have appendicitis if they were that low risk, but may alter some of the test characteristics and have decreased our sample size. And then I think the other thing that was a little difficult and a little bit of a limitation in having done some of this chart review is determining how long symptoms were going on and kind of which it counted as a symptom. So we counted abdominal pain, vomiting, and fever as our symptoms, and we used from the time of the ED note that was written, which nowadays we're a little bit faster to see patients, but when you have patients in the waiting room, determining how many hours a patient had symptoms can be a little bit difficult, and you have to make an arbitrary distinction. And that being said, we also, at symptoms greater than 1 day, really just rounded to the nearest day because it was not practical, very difficult, and probably clinically irrelevant to do so. So in conclusion, CRP adds sensitivity to the evaluation of pediatric appendicitis, specifically for symptoms greater than 1 day and not necessarily in all patients. It's important to note that no lab test showed nearly 100% sensitivity or specificity. So as every good doctor must say, we must place the laboratory tests in the clinical context. So if anyone has any questions, comments, concerns, opinions, anecdotes, monologues, or diatribes, you can, email them to me since I'm not going to take in-person questions. There's my email at the bottom there, and I want to thank you for your time. So thanks.